Hello and a warm welcome to Day 7 at Tata Literature Live. The 11th Mumbai International Litfest is the first one to be completely digital, co-sponsored by Tata Steel and Tata Projects. There will be a 15-minute Q&A at the end of the session, so please do send in your questions in the comment section of the platform that you are viewing from. Ladies and gentlemen, the Indian healthcare infrastructure is unable to keep pace with the demands of the growing population. How can India overcome the challenges of providing accessible and affordable healthcare to the masses without compromising on quality and integrity? Our panel today weighs in. Professor Anil Gupta is visiting faculty at the Center for Management in Agriculture, IIM Ahmedabad, and faculty member at IIT Bombay, an activist for the cause of creative communities and individuals at the grassroots. He is the founder of Honeybee Network, SRISTI, NIF, and GIAN. Dr. B.S. Ajaikumar is a doctorpreneur and the chairman and CEO of Healthcare Global Enterprises Limited. He is a radiation and medical oncologist with over 40 years of experience. He believes that taking care of people's health is good business. His book, Excellence Has No Borders, is an inspiring narrative of the challenges and successes on the path to becoming a doctorpreneur. Mr. Harish Bhat, brand custodian at Tata Sons, serves as a director of many Tata companies and has been with the Tata Group for 33 glorious years. He is an author, columnist and marketer and has authored bestsellers like Tata Log and The Curious Marketer. Chairing the discussion is Anuradha Sengupta, known for her current affairs shows on CNBC TV 18 and CNN News 18. Her latest show is The Media Dialogues on CNBC TV 18. She is known for her intellectual rigor, thoughtful approach, and visual flair. A warm welcome to our panelists.
Thank you, Jillian. That introduction was really nice and kind. I'm sure all of us on this panel are quite inspired careers. I think the topic of this discussion is something that I'm really looking forward to learning from, because I'm not an expert and this is a highly specialized area highly specialized area. And especially having this conversation in the backdrop of what we are all living through, this COVID-19 pandemic, which has helped highlight, or spotlight the weakness system and also highlight the inherent resilience, which has been thanks largely to the fortitude and spirit of individuals, whether it's doctors or nurses or support staff like ward boys and ambulance drivers. So I think in that context, what we are going to discuss today should be interesting for not just people who are specialists in the healthcare system and in this area of our of industry, but also for policymakers and for normal citizens like you and me, for who healthcare became such a concrete thing to deal with, to understand, and to even assess in terms of the quality of healthcare that we have as as citizens have rights to. So yeah, that's the backdrop. Fantastic to be having this conversation and delighted to have this opportunity to talk to all of you. I think I'm going to start by getting each one of you to weigh in on what you make or what we should make of our healthcare system as a collective, given that we are in November 2020, 6-7 months into the experience of the COVID-19 pandemic, something that we've just not ever had an experience of, with 91 lakh cases or almost 91 lakh cases and over 1.3 lakh casualties. So if you look at our healthcare system through this lens, where would you say we are at? And I'd like to start with Professor Gupta.
First of all, I must say that the experience of setting up outstanding cancer hospital chain by Dr. Ajaikumar, which he narrates in his book Excellence Has No Borders, demonstrates that it is possible to make excellent healthcare affordable. I think this is one very important message, that we should never think of trading off that outstanding care for the rich and average and the mediocre care for the poor. So one of the first principles that we should reinforce is that it is possible to provide outstanding health care to every citizen of this country, provided we change the way the health services are provided, are given to the people. There are three very important parameters that I can see learning from the experience of Dr. Ajay and learning from the experience of various health efforts that have been taken up. Whenever you look at Dr. Orale's experiment or a Jamkhed experiment or many other experiments by our friend in Gadchiroli and others, that they have been attempts in this country to overcome the spatial, sectoral, social bottlenecks in our provision of various services, particularly healthcare services, by dedication, by making simple rules apply to everyone. Making simple rules apply to everyone. For example, COVID-19, the physical distancing, the masking, the hand washing are simple rules. So long as they apply to everybody, they are effective. If they apply only to poor or common people on the street but don't apply to rich, they are not effective. And this is very important lesson, that whatever rules we develop for health delivery should be applicable to all. And in fact, the privileged people like us should also be able to take pride in going to a primary health center for our need, for meeting our need. The day it happens, the middle class starts going to primary health centers, I think we would have solved one major problem. Second thing, education. The education of health, medical education, should also produce a little bit more empathy, a little bit more concern for the masses. And there should be, while we have a internship, I just read yesterday, Ahmedabad Municipal Corporation announced that all the doctors who had not fulfilled their bond must report tomorrow at 9 o'clock. Now, why should it be required? Why shouldn't they volunteer? Why shouldn't they go and say, look, this is the time that we have to learn how to provide emergency services. We are all here waiting for your instructions, assign us responsibility, we'll go to the field. That means our education has failed to some extent in creating this sense of devotion and dedication among the students and medical graduates to volunteer, to come forward, to take it as a part of their job to provide health services. And the third is that for a long time, just like in education it happened, we provide outstanding higher education and very poor primary education. In health, we have done the same thing. We provide outstanding tertiary care, very poor primary health care. We have not improved the infrastructure. We have not improved the basic services at the diagnostic, for example. And now the new technologies that are coming up, new startups that are coming up, and I think Dr. Ajaikumar and Harish will elaborate, how do we support these people? If there is somebody who has developed a 50,000 rupees fluorescent microscope, Vikas Pandey from IT Delhi, how do we make sure that the microscope is available in every primary health center to diagnose TB? Without that, you cannot diagnose. If you don't diagnose, you can't cure. 50,000 rupees as against 8 lakhs, that is the cost of a fluorescent microscope. So there are a lot of innovations are coming up, but we do not have yet a process of large scale trial of these solutions and replication and adoption. Public procurement as a driver of innovations, particularly in healthcare, is yet to take off.
Right. Harish, do you want to weigh in?
Yeah, I want to, first of all, congratulate Dr. B.S. Ajaikumar for the wonderful book that he has written. It's such a wonderful story. And I actually want to take on a couple of things that he has said there with relation to the healthcare system, Anuradha. The first thing that he has said there is value medicine, and that in a way also reminds me of what Professor Anil Gupta said just now. The same rules for the rich, the middle class and the poor. Everyone has access to the same facilities and follows the same rules. I believe that when that happens, then there is the concept of universal healthcare that will kick in. So I completely agree with that. The second point I want to make, Anuradha, is we have to make healthcare accessible to a large part of our population. A good part of Dr. Ajaikumar's book is all about that, how healthcare can be made accessible. And if healthcare is to be made accessible, it's in terms of spatial distance, it is in terms of cost. I think at the Tata Group, for instance, we learned that when Eastern India needed a hospital for the large hospital for the treatment of cancer, then we did have to put up the Tata Medical Center at Rajarhat in Calcutta versus the Tata Memorial Hospital in Mumbai, which was not able to support the needs of the Northeast and Calcutta. And that work is being taken forward by the Tata Trust today, who are actually creating a cancer grid of hospitals across the country. Yeah. So I think that access is very, very important. And that access can be put up by non-profit as well as by profit organizations. And Dr. Ajaikumars book actually talks of both. So those are 2 points that I'd like to make to supplement what Professor Anil Gupta has said.
Dr. Ajaikumar? Your book has inspired everybody who's read it. I spent a day, catching up with the story of Healthcare Global and how it was started. You want to weigh in on how the COVID-19 pandemic has, helped us assess the state of our basic healthcare system?
Yeah. Before that, I just want to add to what Professor Gupta and Harish Bhat have said. When I immigrated to US in 1975 and saw the way healthcare was addressed, and as I started visiting India back and forth in the 28 period and finally moved to India, I looked at the enormous gap we had in the healthcare between the two countries. It is not really, everything is not related to saying that we are a emerging market, we are a poor country, we are a rich country. I think it is how we address these basic healthcare issues. And the government, it spends only 1.5% of GDP, that is about $83 per person, and saying that I want the same care as what US spends $9,400, or entire Europe, which spends about $5,000, China spending $6,600. It is not possible for the government system to achieve this goal. Simply saying I am going to create schemes, I'm going to do all this, are really not an answer. What we have heard today, both speakers, very clear that we need to reorganize ourselves and look at rich or poor. The cancer, for example, or heart disease doesn't know who is rich or poor. Cancer is cancer. It has to be treated the same way. You cannot say I will give a low-cost treatment and I will cure you when it is not possible. And that is where the addition of value-based medicine comes. In fact, in India, even including COVID period, we have done extremely well. Our cost, when you look at the global comparison, for the apple-for-apple comparison, if you do, we are one of the cheapest in the world. We are low cost. But if you keep on talking about cheap healthcare, then there is a cost to low cost. And that is where we have found the mortality rate, morbidity rate very high. And again, we have not placed enough importance to primary care. I used to come to India every year and do camps. I must have done over 1,000 camps. And for me, it was pathetic. We did a World Bank project where we showed 150,000 women were anemic, below 9 hemoglobin in the reproductive age. And we are below sub-Saharan region. But system is not addressing it. Instead of that, we are talking about very high-end work and now. See, there has to be clear delineation. What is the public sector going to do? What is the private sector? 78% of healthcare in India is by private healthcare. And it is, India 1.2 billion has different countries within one country.
Yeah,
300 billion can afford, whereas the other people are not. So how do you bridge the gap? All of this is mind-boggling. But unfortunately, the decision makers are all bureaucrats, as I feel. How can you be dealing with metro project one day and you become health secretary next day and start telling the health expert this is how to run the system? No, we need technocrats. We need experts in the field, a panel's discussion like this, what we are doing, to come up with what Mr. Harish Bhat referred to as a universal health care. Simple solution, is very simple, which I've proposed several times. Everybody has a cell phone. Put a surcharge based on their income abilities or their job, what they do. It may be a merchant, it may be a small shopkeeper, it may be an auto rickshaw driver. So each one of them gives and a rich person contributes more. Create that pool of funds out of which we can take care of everyone in this country because of value-based medicine we have. We can leapfrog and provide excellent care and compete with leaders like United States or Europe and get the same outcome. Value-based care is very simple. What in HCG we have achieved. Same outcome at much lower cost. The data proves it. We have proved in breast cancer, we have proved in oral cancer. So coming to the COVID issue, again, accessibility is important. That is what we have done with 23 cancer centers across India. People don't have to travel, but with high technology. Every one of them will access linear accelerator and PET scan. This has to be done. Rich or poor doesn't matter. Create after hours treatment, like maybe 8 o'clock in the night, you want to treat a free case. Why don't you do that? There is places available. So this is how, in fact, Harvard Business School, when they did a study 5 years in a row, called us Robin Hoods. Now we have to do that, create that cross subsidy. So when we come to COVID, one of the things we have learned in the COVID situation very clearly, we are, when the lockdown was done, everything was done, as we said, our numbers are lower than the West. Whether it is because we are not doing testing, we are not doing something, we don't know. Because people expected India to be in distress by now. Fortunately, we are not. We are understanding it is very complicated. Is it immunity? Is it because some of us are exposed to tuberculosis? Is there a built-in immunity? Why is our survival high? It is a study in progress. It is a study in progress. So answers to this only will come in about 6 to 8 months from now. But I believe that we have done an excellent job. I think we should stay on course, and mortality rate is low, but still, we are seeing some unnecessary deaths. We need to address and learn from it. It is a learning curve right now. Everyone in the world is learning, and India fortunately has had less mortality, and we should pat ourselves on the back and keep this, like what Professor Gupta said, mask, distance, hand washing. Mask has become the most important thing right now, and that has to be followed diligently.
And followed diligently irrespective of who you are, isn't it? That's also what he said. The same rules applicable for everyone everywhere. Yeah, I wanted to get you all to react to the work that Ayushman Bharat or the PMJ scheme has done, which is bringing in about 50 crore, 50 people under a basic insurance coverage. How do you health insurance coverage? How do you see that as helping to create more accessibility to basic health care across the country? Professor Gupta?
I would say that Ayushman Bharat does take care of the hospitalization and other costs, which indeed is very high. One bad episode and your 5 years savings are gone for a lower middle class person or a poor person. So therefore we should recognize that all the improvements in livelihood, all the improvements in income generation can be wiped away by one adverse consequence. So in that sense it fills a very important need. But equally important is, or in fact to my mind more important, is preventive health. We are not investing enough in preventive health. We are investing more in curative health. And I think preventive health is much more democratic, much more affordable, much more accessible. And that I think should also get attention. There is a need for a very large mass awareness, mass capacity building program. Our education system is not rising to the occasion. Every school, for that matter, should become a hub for preventive health care, so that right from the childhood children can learn. And even currently, the colleges and children can do both for their own sake and their parents' sake, their grandparents' sake. So children should become a very convenient, very optimistic, very futuristic channel for conveying the essentials of preventive health. To give an example, Dr. Ajaikumar mentioned about anemia among women. 60% women in India are anemic. It's completely avoidable. Poverty is only 20%. Why 60% women are anemic then? Why? Because there are two reasons. One, our utensils, iron utensils have gone out of the kitchen. Where will the iron come from? We are not using them. And if you just, there's an experiment on magic iron fish. 128-gram cast iron fish put in the curry provides enough iron for family of 5 for 5 years. It is so affordable. With little bit of lime juice, because citric acid is required for making it available to body, you have solved the iron problem. There are such simple solutions available. But who will tell this? I talked to the railway ministry once that can you announce this, that cutting vegetable, washing vegetable after cutting and washing vegetable before cutting makes so much difference to free amino acid. The nutrients washed away when you cut them and then wash. Simple principles of preventive health. For same amount of money, you get more nutrition if you wash and then cut instead of cutting and washing. So these are the simple principles which we are not sharing. We are not educating our people. Similarly, in child delivery, Assam has very high maternal mortality rate because of the practices that are not informed enough. So we need to really make available knowledge accessible to as many people as possible through programmatic intervention, not just by random choice, just that somebody comes to know and somebody doesn't come to know. In the age of media and all of that, the scientifically valid information should be made democratically accessible to everybody, not just as many, everybody.
Right. Dr. Ajaikumar, how do you react to the kind of work that this policy initiative of the Ayushman Bharat program and PMJ has done? Are you all empaneled? Is any of your cancer centers empaneled?
Yeah, we are, but I feel that the intention is good, but it is really misguided. It is not a solution for the massive problem we face. One of the things Professor Gupta also mentioned, prevention is very important. I know we need to take for example cancer or heart disease. We know what the effect of chewing tobacco, smoking, head and neck cancer is so common. We see a lot of it in our practice. Simple, either by banning tobacco, which we are very actively proposing, or even reducing the nicotine content, or the BDs which people smoke. It is high cause of oral cancer, oropharynx and all. So even simple thing like that can avoid 40% of the mortality related to cancer and heart disease can be avoided. Having said that, in terms of Ayushman Bharat, it may be a step for the universal healthcare, but it is a low-cost provider which does not address the issue of cancer for everyone treatment. For example, recently I had a lady who's 24 years old with breast cancer, who requires certain treatments for long term. She's a triple negative, requires certain drugs, certain medication, targeted therapies, which would not be allowed under the scheme. And our center in Andhra Pradesh did not treat her properly because of that. And she died. In our mortality review, when we reviewed it, we were aghast. And of course, these are happening everywhere. These are some instances we know. But unfortunately, the right treatment, cancer is very unforgiving. So also a lot of other disease. If you don't do the right treatment at the right time, the disease will come back. And it is not easy to treat when it comes back. So first time right treatment, if you want to give, irrespective of the socio-economic condition and all, there has to be universal healthcare with no limits. Essentially, that means let us treat this patient with 25-year-old with breast cancer the right way so this disease will not come back. Doesn't matter what the cost is, what the technology needs to be used. You need a PET scan. A lot of these schemes don't allow for a PET scan. Imagine a PET scan is a gold standard to diagnose the right stage of the disease. So what is these schemes are serving? Because they are supposed to be low cost. They are working. See, the bureaucrats first put the cost first, and then what should be the treatment. It should be the other way around. Let us do the right treatment, and let us analyze what is the global cost. What does it cost for HCV to do this? What does it cost? In fact, the important thing is to analyze what is the service cost to provide the drugs, technology. How do you, like for example, HCG doesn't give out any dividends. We may be a for-profit, we may be a listed company, but we don't give out any dividends. Why? We flow the money back into the system to bring in higher technology, higher talent group across India. We have revolutionized cancer care in this country by taking it to tier 2, tier 3 cities, not using any grants from government, not a single piece of land from government. How did we do? By creating this model, which is what a lot of business schools, 63 business schools study our model, because this is the model for future. Value-based medicine, flow the money back into the system, begin the technology, because cancer care, what it was 10 years ago, is totally different from now. By some standards, every 3 months cancer care changes, because we are getting that kind of outcome. Imagine people with lung cancer living for 8 years, 9 years with advanced disease. So this was unheard of in the past. And imagine conquering cancers like cervix cancer. And imagine breast cancer, people with 10 years survival over 90% in early stages. Even advanced stages living for 8 to 10 years. This is something. I have a person who is volunteer for me, 8 years breast cancer in liver living. She's a sociologist, head of the sociology. She was chairman woman for the sociology of India. When we have such cases, why should a poor man not get the same treatment? Poor women get the same treatment. That is where we are at crossroads. I think this can be broken only if we develop universal health care with no limits, treat the right cases, whether rich or poor, let me give the person the right treatment. If they require radio surgery, IMRT, if they require, limited surgeries, like, targeted surgery, they should all get. We cannot, I am tired of hearing our doctors across in tier 2, tier 3 cities telling me that, sir, we could not treat this case because the scheme did not allow. Which is totally, and the disease comes back. It is unbelievable. What we see in head and neck cancer, breast cancer. We do our tumor boards, we do mortality review, recurrent cancer review. I get so much insight into real practical, not the bureaucrat sitting in the armchair and advising. Real life stories of people and real feedback from them and learning what went wrong with these patients. And that is the essence of the right treatment at the right time. And that is why, anybody who goes to ICU, if they don't have insurance or the scheme doesn't pay, pay 5 lakhs or 10 lakhs, it's very expensive. How can they pay from their pocket? It is inexpensive compared to the world standards, but for that particular person, it is expensive. Because he has to pay. How many of us save 8 or 10 lakhs in our bank account? So that is where universal healthcare is going to make a difference. And that is what our system has to do, and spend more money for healthcare. Hello?
Hello, we have lost it.
Yeah, I was sorry. I'm really sorry, everybody, but I seem to be, having some poor connectivity at this point of time. But I just, Dr. Ajaikumar, you make this very impassioned case about schemes, whether it's Ayushman Bharat or government subsidized, not enabling you to really go, hell for leather and give each person the kind of treatment they deserve, especially in the field of cancer, which is where you specialize. What is the solution, given that the government, even to fund the Ayushman Bharat outlay, has found it difficult? You just talked about what are, what percentage of GDP goes into healthcare. How do you expect this? Where do you expect the solutions to lie?
I think the solution is, unfortunately, as great philosophers Voltaire said, common sense is so uncommon. I think here we have to use common sense. Common sense is very clear. I am myself in a recipient for US Medicare, because when I was young, I paid for Medicaid tax. Everybody paid. So today I can go to any US, even though I'm not a citizen of the US. Now I've given up. I can go to any US hospital and get free care, unlimited care, using the Medicare card, because I paid tax on it. So similar system where India is full of youths, Anuradha. We have 65%, 70% youths. They are not supposed to get sick. So they can contribute to this universal platform of healthcare cess. And you create billions of dollars. By some estimate, India needs about 150 billion or $200 billion. That will increase our per capita usage for healthcare to almost $200 per person. If you can achieve the 200, we are in a great shape compared to other countries to bring about equal care to everyone. So this can be done. It is not very complicated, because as you know, everybody has a cell phone. Everyone has a cell phone. You say if you are paying 1,000 rupees a year, you please add extra so much percentage cess to that. And also that depends on your job description. So if somebody is earning 10 lakhs per year, he may contribute several thousands a year. Somebody is earning only 1 lakh, he may contribute 1/10 of that. That, in my calculation, what we have done, propose, that is suffice to bring about a decent universal healthcare. And based on that, we can develop it into a more mature. See, we cannot become an advanced country. We talk about sending rockets to the moon, sending rocket to Mars and all. I think that is not what we should be doing. We should be taking care of health and education. If we want to become an advanced country, health has to be, you have to have a universal healthcare card to every individual who shows the card and gets the right treatment. It is not kind of a low cost, cheap treatment. It has to be right treatment. It could be low, it could be cheap, but it has to be right. That is where we are lacking today, and the answer is universal healthcare through the model which we have proposed, and a lot of others have talked about it, like Thailand can do, Malaysia can do, China can do. All these countries have done it very well. Even countries in Brazil, for example, everybody carries a card. Brazil, is almost equal to India in terms of advancement. Why is it these countries? Colombia, I have been to Colombia. I taught them how to do universal healthcare. When they can do, why can't we do? Because we have too many bureaucrats, too many people who are not listening to the right kind of people. They think they know the best. It is time we cut down this bureaucracy, bring it to a level where common sense approach is taken, and we bring, nobody will complain to pay few dollars more per year to bring this universal health care. That is the only answer for this kind of a problem.
Harish, what do you think? What is the way forward? How do you bridge this gap?
Yeah, so Anuradha, I'm not a medical practitioner like Dr. Ajaikumar, but I've been a marketer all my life. And let me talk about, the need for very simple messages towards preventive healthcare. And this is very important so that the load is taken off the healthcare system and we lead much healthier lives. I want to give you two examples, Anuradha, from the Tata Group, which I'm familiar with, where it has helped greatly. One example is a very simple example of Tata Salt, as you're aware, is the country's largest brand of salt today. But why did it become the country's largest brand? Because it was iodized salt. And there were very, very simple messages to consumers right from the time it was launched on why iodine is good for you, why it will take care of goiter, and why it is important for you to have iodized salt and not non-iodized salt. And that has helped greatly in bringing down that issue across the country. But then as a marketer, my lesson there, Anuradha, has to be have a single simple-minded message on what is good health, what do you need to do to prevent the onset of heart disease, for instance, or what do you need to prevent the onset of obesity, for instance. I believe that we need to have a fusion of very simple marketing with the right principles of healthcare. That's the one point I want to make. The second is, of course, Anuradha, the point which was made earlier, both by Professor Anil Gupta and in Dr. Ajaykumar's book, the right technology. So very recently, the Tata Group has launched, Tata Medical and Diagnostics has launched Tata Check, which is a CRISPR-based COVID testing solution. And that is based on technology, new technology which has got protein-based technology which has been developed. So I think we should have more and more startups looking at developing technology for healthcare in the future, and look at how those startups can be encouraged and funded. That is a second point that I'd like to make. So I think the entire startup medical technology space, as well as the preventive healthcare taken through very simple marketing principles across the country in the manner that iodized salt succeeded or pulse polio succeeded. I think we should take inspiration from some of those voyages of the past as well. That's those are 2 points, Anuradha, that I would like to make.
Professor Gupta, I'm not able to see if you're on the conversation. Professor Gupta?
He's there. I don't know what happened.
Okay, maybe he's having connectivity issues as well, clearly, but Dr. Ajaikumar, private companies, private hospitals that offer medical care, even during these COVID times, I keep referring to COVID because we are still living through this, and all of us have been assessing what kind of healthcare we have access to and what we can afford. We've had governments have to step into rates, isn't it? How, as a practitioner and as someone who set up these 22 centers across the country to deal with cancer, no less, where do you see the role between, profit, the profit motive that stimulates entrepreneurship and allows you to scale up, and service which allows you to offer the best possible care to anybody who needs it? Where do you see the trade-off between these two? And do you think, and would you, private hospitals and private infrastructure is, tends to prioritize profit over patient care?
No, to be honest with you, I have seen the global market and the Indian private healthcare system. I think it's one of the wonderful journey to see how Indian private care, in spite of all the negative sometimes publicity we get on the usage of certain charges to the patient and all that, when you look at the real returns, how healthcare has been managed. For example, in the own HCG case, as I said before, we don't give any dividends. And when you look at the profitability, how do you measure profitability? What is your margins? What are the margins? So most of the hospitals, private hospitals in India, who are even listed hospitals, and
like your own, yeah,
our own, margins are always below 20%. And whatever margins are required, obviously, to take care of servicing your loans. As you know, the EBITDA, what it comes, you're using that, you have to service the loans, more technology and all that. So essentially, most of our, PAT and all that are barely positive or negative. So, this is very clear that the profitability margin in the for-profit hospitals is not very high. And some of the mature hospitals which are there for a long time may be having close to 18-20% margin, giving out some dividends, but majority of them are not. So what does it tell us? That whatever money they are making is using for technology and talent. In fact, I have to take this opportunity to compliment the private equity, which has played a major role in investing in healthcare. So if you look at our own journey, we had 7 private equity players, including, Mr. Azim Premji, IDC, then we had Singapore, Timesat, Quadria. All of these people invested and got a good return. Because for me, when somebody invests, trusts you and invests, it is imperative they get a return. But are they going to get a return of 30-40% per year? No. If they get a return of 15-18% is what we feel they should be satisfied, and most of them have got that kind of return and exited from us. So there is a return on investment, but it is not like a loan because you don't have the sword hanging over your neck. Of course, we know equity is more valuable, but still you don't have a sword. This is how successfully you can manage. Using the equity where there is no dividend, but the private equity want 2x, 3x. In that process, actually the healthcare is benefiting a lot because we have access to technology, good doctors, everything. Our own revenue, when you look at it, what was our revenue 10 years ago, and now it is significantly higher. But we have used the whatever we generated out of it, EBITDA positive, to bring more technology and expand to 22 centers. We were only 1 center in 2007 or 8. From that, we have expanded using the private equity. So I do believe private equity with a theme of social impact are a major contributor to the healthcare in India today. But they are unsung heroes. Nobody talks about them because they are into private equity. They are supposed to have greed, but that the social impact factor, like you take only cancer for what has happened to us, is enormous. It is very difficult for somebody to judge how you have put a high technology in Onco, Nasik, or Vijayawada. There no cancer treatment existed 10 years ago. How we have revolutionized all of this because the private equity said, let us do this. And whether it is part of the social impact, whether they thought or profitability, it's for them to decide. But the impact has been there. So this is one way where without government support, without government involvement, it is possible to achieve these goals. And that is what I think in my book I have tried to show. While there is, issues of transparency, while there is issues of bribery, all of this, government being bureaucratic, all this, the license Raj, everything was there, which when we started all this, we could overcome all that because, of the single mindset. We want to make cancer care accessible, affordable, and use the effort of private equity. Say, I want my return. So there is one return for them. Whereas the public has got help because we brought in such kind of care, enormous change, game changer across India. And we as doctors are happy because why did we become doctors? We struggled 12 years to become a doctor, Anuradha. We have to do MBBS, MD, DM, everything, you name it. All of that, why did you do? Because we think of patients. It's not just 15 minutes you go to the patient and talk. It's a day long. Right now, I have a very sick patient who's in famous nuclear physicist in my ICU. Day and night, we worry about it. How am I going to bring? What am I going to do for her? It is not just a process of going and seeing a hospital and your job is done, lock the door and come. You are in it. You live through this. You should see the experiences these doctors go through in COVID time. They have braced themselves and went to the front line. Majority of the doctors from outside got COVID. They came out of it, fortunately. But they were front line. They are unsung heroes. But government did not even give one stimulus for private healthcare. One stimulus. They did not give 1 rupee for private healthcare. So I am telling you, there is great misunderstanding, misguidedness, how we are going to do. Government has to decide, am I going to be a monitoring or am I also going to do service and compete with private? My view is very simple. Government should monitor, make sure everybody is treated well, and make sure the funds are given in terms of insurance. So we in private or whatever you want to call non-profit can provide. Will take care of the solution. Government, I will also put a cancer center. I will also do this. I will also compete. That doesn't work. You know, there is no way. Why do people, even the poorest of the poor, doesn't want to go to government center?
So Dr. Ajaikumar, are you saying that government should exit all hospitals, even at the primary level,
No. Only in the tertiary level they should exit. They should not be in the tertiary level to begin with. Primary they should focus on. And at some point, gradually, they should, they should empower the enterprise, but there should be monitors. They should monitor to make sure, suppose, government wish is to say, you are a BPL patient. You should get the best of cancer care. They should use the data to see, is this person getting the best of care? So then what does it matter? Whatever government spends, let them give it to private, and we will create a universal health care. And in this return, government becomes monitoring. That is how in US it is done. Their government insurance, Medicare monitors, Blue Cross, Blue Cross monitors to make sure you are getting the right treatment. So that is, even in UK, that is what is. So we need to really establish that system. What is the role of government? What is the role of private? It has to be clearly articulated. Right now, it is mixed. Nobody knows whose role is what. It has to be articulated.
Harish, okay.
Yeah. My, Anuradha, my views on private health.
The thing is that, Dr. Ajaikumar makes a very impassioned case about the good doctor, and we have seen how doctors, like he reminded us, have been at the front line today. We've seen this in front of our eyes. But having said that, we also know that it is, if the government does, and if India does what he's suggesting, which is provide all specialized healthcare under the private. Into the private sector, there may be so many people who are not able to access services.
No, they will all access, because there will be much more. The penetration into the second tier 2, tier 3 cities will happen rapidly, like we have penetrated. So they will be accessible. Today, if you see in Onco, there is no government hospital. We are the only cancer center, or in Nashik. So this is how it will spread. Once people know that this is a viable project, there will be multiple HCGs. HCG not down, there will be multiple. So I think this will solve, and government can also focus on primary care. I think this is the best of both worlds.
I agree with Dr. Ajaikumar. What he has been able to do, what this book lays out very clearly, Anuradha, is not just in large cities like Bangalore, but he talks of Shimoga, he talks of Mysore, he talks of Nashik, he talks of towns in Gujarat. He has been able to provide accessible healthcare in each of those locations. But more importantly, Anuradha, I'm going back to my roots as a marketer. He has been able to do that under a sharp brand called HCG. All these hospitals, because at the end of the day, you have to make the healthcare accessible in these tier 2 towns. But you also need to have hospitals which are trusted, private hospitals which are trusted, so that this view that hospitals are probably profiteering needs to go away from layman consumer's mind. And a brand always helps you build that trust as long as your behavior is consistent towards your consumers who are the patients. That I admire in what Dr. Ajaikumar has done. In the story, he even talks in 1 or 2 cases of people who wanted to make a change in that brand, but he did not permit it. He convinced them to keep HCG as the brand name. And what does HCG stand for in the minds of patients today? If it stands for trusted healthcare in the area of oncology, if it stands for, Dr. Ajaikumar, for instance, has spoken very early in the book about something called Onco Philosophy, his philosophy of encouraging patients to pursue their life even as they are getting treated and achieve their life goals. So if the brand stands for those kind of attributes and then penetrates into tier 2, tier 3 towns with accessible healthcare, I see every reason, Anuradha, that the private sector should be able to provide good healthcare in Tier 2, Tier 3 mainstream India.
Right. I can see Gillian, I think we've got questions that have come in from people who've been watching this. So I'm going to just put a break on our conversation and expand it to include people and their questions. So Gillian, why don't you go ahead?
Thank you, Anuradha. This has been a very engaging conversation. Unfortunately, we've had some trouble with Professor Gupta's connectivity, but we have received a lot of questions from our audience. Our first question is from Shaurya. What are your views on the progress of medical tourism and the challenges associated with it?
Dr. Ajaikumar, I think you should, I think you can take these questions. Yeah,
yes, I think Dr. Ajaikumar, all medical related questions, I think Anuradha, certainly Dr. Ajaikumar should take.
Yeah, thanks. Yeah. No, medical tourism in India is a vast field. It is tapped, is not being tapped to the potential. If you look at, for example, in the US, Mayo Clinic or MD Anderson, the medical tourism, medical destination is a significant part of the revenue. And it can actually cross-subsidize for your domestic patients, particularly, lower socioeconomic. In HCG itself, in a center like Bangalore, about, close to 20% of the revenue before COVID was international patients. Because why do patients come? Like we had the finance minister of Tanzania come, because he said he went to Harvey Street, saw Indian doctors for cybernetic. We went to New York, Sloan Kettering, saw Indian doctors. He said, hey, let me go to the land of Indian doctors and take treatment. So we are good. Our doctors, if you go anywhere in the world, you will end up meeting the Indian doctors only. So we are good. We should pat ourselves on the back. In fact, there is a Harvard study showing Indian doctors treating Americans, they live longer than the local doctors treating Indian origin. So we can be proud of it. So we have to understand, we have to take pride. Using that pride, I think Indian medical destination, because we are value-based medicine. Some of our patients who come from Middle East, Africa, when we interview them, they were going to Europe or going to US. But today they say, hey, I can come to India and get it at one-eighth the cost. Why should I go elsewhere and get the same treatment, same technology, cybernetic, same high-end radiation, and get the same outcome, and same Indian origin doctors are treating? So I think this is a game changer. But one request is, government should not interfere. Once government interferes, I think this will go away. Because right now it is working out very well. People go to US Indian embassy, get their medical visa, they travel, we give them the treatment. I think this advocacy group, somebody saying that my international patients were treated this way and that should stop. We all do quality analysis, data analysis, we produce our data. Everybody knows in the world how we produce. So government should insist on putting out data. Everything is in data, Anuradha. Everything is in data. If you treat a breast patient, what is your outcome? If you treat a head and neck patient, what is if the patient is in ICU, what is the? I think once we are in that now, we are putting out that data clearly says which is under people who come from Africa, Middle East decide. So India being a medical destination is a huge opportunity. I think we should go that way, and that will really cross-subsidize a lot of our patients and bring a great name to our patients.
Yeah. So Gillian, I think you should do that. Read the next question.
Sure.
Ajay, would 20% of your revenues being, from foreign patients, would that hold true for the private sector in general, you think, 20% in that region?
Our Bangalore center is from there. Yeah, normally for big cities, it holds good, 20%, right. 18 to 20%.
Okay, Gillian, give us the next question, please.
Thank you. The next question is, what important points should India keep in mind in developing a comprehensive universal vaccine distribution program for COVID-19? I fear this is the biggest challenge that we have to encounter in the future, and this is from Smriti.
Doctor, I think.
Yeah.
And
Yeah,
if you want to add.
The important thing is vaccination. We have the serum. I think the ability to produce a high quality vaccine is there in India. We are one of the leaders. People know India is a leader in vaccine export, production export. So I think we are well entrenched to produce massive vaccination for millions of people. But the phase 1 should be for the frontline and people who have comorbidity. So if we can do it for people above, like for example, 60 and above, people who have diabetes, people who have a major other illnesses, cancer, and people who are healthcare workers, that will involve maybe possibly about 30, maybe close to 100 million. So we need to really take that as the first priority in vaccinating, because youths, 65% of the population being youths, they could be after these people who are highly susceptible or treated. That is how I think we should do. And we are very well positioned to achieve this goal. I think we are possibly much better than even some of the European countries to achieve this goal. And once the Oxford or the vaccine which is already being produced in the Pune Institute, if that is approved, I think in a massive scale it can be done. I'm very positive about it.
Okay.
Harish wants to add anything?
No, Dr. Ajaikumar, I think you have covered it well. Nothing that I want to add on it.
Thank you. Shall we move on to the next question, Anuradha?
Yes, of course, Jillian. Yes, please do.
Okay, so the third question is, why has investment in health and education, for that matter, been so low in India?
It's a good question. You want me to take that?
Yeah. Please go ahead. Please go ahead, doctor. Please go ahead, doctor. Yeah.
No, I think that
the gloves are on. He's taking everything on the front foot. Go ahead.
No, investment in health and education, although particularly health I can address, is because one of the great things which happened in the past was transparency was not there. People who wanted to invest in healthcare lost a lot in the beginning. We are talking about 90s or early 2000, and because a lot of the the hospitals were run by individual doctors, nursing homes, and there was cash collection, and people did not account for this. So for a private equity to come and invest or look at it, where is the transparency? Half the money was not there. Where is the money? How much is the doctor people taking out? How much is the tax? They always showed they are paying very low tax, and they were driving Mercedes-Benz cars. So what happened here was, there was no mixing of the two. So people felt very uncomfortable investing. So once we saw a corporate hospital kind of come into existence, clarity, transparency, accounting, not 1 rupee going out of the system, everything being given by checks. This kind of transparency has impressed people. So now they are beginning to do. Entire HCG story is that if you look at even other corporate hospitals, all of them have done well on investors. But it has not gone to the scale we would expect, because still there is, for example, fear of drug control, some price control on actual procedures. The government interference, again saying, it's giving some nervousness to private equity investors. And this has to be addressed at the right time in the right place, to say that the government interference should look, as I said, they should monitor the costs. They should look at what is the cost, universal healthcare. Once universal healthcare comes, I think it will be a mega investment in healthcare. Whatever we are seeing is small, but it will be mega investment, because for the investor it is secure, it is recession proof. Health is health. Somebody is going to get cancer whether there is recession or no. So I think this will be positive for the macro environment and healthcare completely. And similarly, you can talk about education, but once we know the government is only monitor and there's a universal healthcare, there's no kind of draconian measures are not going to come. So one of the things we have seen last year is huge measures on the price control on drugs. And why should a person driving a Mercedes-Benz also pay 100 rupees low price as somebody who's a farmer? It doesn't make any sense. But uniformity should not be there like that. So that is why, we have to look at the ways to create this universal healthcare, So let the system take care. I will monitor, and that will bring in significant investment in the healthcare.
Wonderful answer, Dr. Ajaikumar. Would you like to weigh in, Anuradha or Mr. Bhat? Or shall I move on?
Please go right ahead. Please go right ahead to the next question.
Right. So the next question is in two parts. Fundamentally, should health services ever be for profit? Does this not create perverse incentives? This is the first part of the next question. And the latter part is, won't there always be a challenge with profitability being the prime motive of private equity? So basically, should health services ever be for profit?
Yeah.
And does this not create perverse incentives?
I think Dr. Ajaikumar actually did.
Yeah.
I addressed it.
I think Dr. Ajaikumar has addressed it, and if I can add Gillian in his book, there are both examples. There is an example of a non-profit facility he created, and there are examples of profit facilities he created, and he has brought out in his book the difference between the two and how both these were treated. But to me, I think health services, like any other sector, the earning of a fair profit is something that society should, falls within the bounds of society. And I think Dr. Ajaykumar's own group, HCG, has shown how that can happen. He's also mentioned very clearly, and I'm mentioning this on his behalf because I was so enthralled reading it in the book, that HCG believes not in dividends, but in taking those profits and plowing them back into more healthcare facilities, which I think then is a very noble cause, because those profits of the organization are going towards creating more healthcare facilities rather than feeding dividends to the shareholders alone. So those are 2 points, Anuradha, I thought I would make in response to the first part of the question. I will of course request Dr. Ajaikumar to, if he comes back on the screen, perhaps to address the second part of the question.
And the second part was also on the profitability, I think. Right?
Yes.
Julie?
Right. Yes, sir.
No,
The profitability, and also, how does one shift the attitude towards social impact factor?
No, I think one of the things is, when you look at the doctors, when you look at the healthcare workers, it is, what is it their remuneration is? What is it, I think there is some misconception that unnecessary tests are done in private healthcare, unnecessary things are done. Maybe like every other business, there will be 5 or 10% of the system which is abusing. So it will always be there. Whether it is healthcare, education, or technology, anywhere, there will be certain irregularities in 5 to 10%. That has to be corrected. They have to be punished. But in India, what we don't see is how many hospitals who does this irregularities, or doctors, or where their license are taken off. But I think that kind of some punishment has to be there for people who are not following the rules, not in a transparent way. Having said that, I think as we go forward, there is no conflict of interest the majority of the time for the doctors or the hospitals, because today quality measures are very important. Even the patient who walks in, Anuradha, I can assure you, majority are middle class or upper, they would have gone through Google, they would have done a Google study on not only Ajaikumar, HCG, everything, what is the outcome, everything. People are, they would also consult some of their relatives abroad. So these are all the things which are happening. So this kind of vetting is going on in a massive way. So no hospital can survive by saying, I'm going to do some unnecessary tests, unnecessary thing, unnecessary surgery. These are all done. Even in US, for example, recently a doctor was punished because he did unnecessary hysterectomy for 20 years. How is it he got away for 20 years doing unnecessary hysterectomies? So for money's sake. So all I want to say is there are some of these bad apples which are there. Just because they are there, you cannot say entire, the medical service provider are not correct. So because today, the type of care we do, this is what we are doing is we are creating even fear among the Western countries. If you look at, unfortunately, you look at Lancet, a very well-known magazine, we had a nice article published. It was so good article, outcomes were so good, Lancet they were accepting it, but one of the reviewer put a question, Remember this, I have the email. Remember, this is coming from a third world country. Because they are afraid, they are concerned that we are able to produce such good results. They think it is not possible because we are India. I think it's nonsense. Today we are able to do that. World has to accept it. Unfortunately, we have not moved towards that level, but we are moving research to reality and all. Once we do that, we can play a dominant role in the global healthcare also. And the private, I think, is there to stay and it is provide a high quality of service. That is why politicians, everybody goes to private hospital. Where if you go to the government hospital, why do they do that? If they really think so bad, why are they going and getting their care in the private hospital? It's very clear. When it comes to their kith and kin, they want to go.
They want to go to private hospitals. Yeah. Okay, Jillian, I think how many more questions do you have?
There are a couple of questions
standing in the next.
Anuradha, I think we're running out of time. So would you like to close the session? We're really actually over
one more. Okay. Over.
Yeah.
Okay. Okay. Dr. Ajaikumar, Harish, Professor Gupta, I think it was quite an eye-opener of a
we lost
Anuradha
about the platform for that. Am I audible?
Now you are. Your voice is breaking in between. There seems to be poor connection.
I think we really had a connectivity issue session. I just wanted to say thank you to the participants. Dr. Ajaikumar, extremely impassioned, very measured as always. Professor Gupta, absolutely passionate again. It's a pity that we lost the connection to him. We've not been able to have him back in the conversation. Point with the digital. Thank you for your questions. And platforms like all conversations.
Incidentally, we may have visually lost Dr. Gupta, but he's been listening in on the conversation, and he has one last statement to make before we close. He says that high quality education needs high quality hospitals too. Top quality medical education still is in public sector. So we need to blend both. But true that more public resources to public health care. These are his closing statements. He has been listening in. Thank you, Dr. Gupta, for sending in this message.
Yes. Actually, I wish we could have had him just his voice participate, because Dr. Ajaikumar was making such a strong case for the private sector. It would have been good to have Professor Gupta come in and let us see the other point of view, because he has such strong views and such a ground up view of what that would entail. So it's a pity we were not able to have him on this conversation throughout, but I'm sure people can reach out to him and read his views. Thank you, everybody. A lot of people wanted to know if I would, I had committed to be on this session. A few people asked me to check if I was going to do this because of what happened. Yes, it's a commitment I've kept because I've gave my word. I'm not sure that sessions should be cancelled. Harish, I will not put you on the spot on this. I will invite you to my show on CNBC and ask you and Anil about the festival and why Chomsky and Prasad's session was dropped or cancelled. The point is, keep a commitment to encourage platforms, keep going. So thank you, everybody. And for people who want to know whether I would come on, this is what I have to say. Thank you.
Thank you, Anuradha.
Thank you, Anuradha, for a wonderful moderation. And I think I enjoyed the whole talk. Thanks for the great interaction. And I also got some insight discussing with you all. Thanks. Thanks, Hari.
Thank you, Anuradha. Thank you, Anuradha, for the wonderful moderation. And thank you, Dr. Ajaikumar and Professor Gupta. Thanks a lot.
Thank you to our panelists for this very important and thought-provoking conversation. Thank you for being with us today.
Thank you.
Thank you to our title sponsor Tata and to you, our audience, for joining us and also actively participating by sending in your questions. If you wish to purchase Dr. Ajaikumars book, Excellence Has No Borders, do log on to our bookstore partner Tata Click. Coming up next at 2:45 p.m. IST is a session titled There's Always Room for Rum. The launch of Farooq Dhondi's book, Rumi, a collection, followed by a discussion on why Rumi is a poet for all humanity. See you there. It's the last day of Tata Lit Live, the 11th edition. Do join us.